Next, we are happy to have Professor Methee, Associate Professor of Division of Infectious Disease and Tropical Medicine from very big hospital and a very important university from Thailand. Let's welcome Professor Methee.
And thank you, Dr. Chen, and this is my honor to be here in Hanoi. This is my first time in Hanoi, and I can see a lot of development and the changes of the city. The first time was about 15 years ago. That's quite long. Okay, the topic of my talk today is the challenges in the management of invasive candidiasis. So this topic is like a summarize of all of the topic that all of the speakers have already addressed this morning. So some of the data that I'm going to present today is pretty much probably the same as you already heard this morning. So in the past, we thought that the sepsis or some of the infection, the serious infection in critically ill patients are caused mainly by bacteria, but lately the fungal pathogen play more role as a cause of the sepsis. As you may know, that there are increase of the incidence of the fungal infection in the septic patient. And Dr. Tran this morning have already mentioned that there are study in the United States showing that Candida species has been found as the fourth most common of the bloodstream infection in the U.S. hospital following the gram-positive bacteria, Coagulase negative Staph auris and the Enterococcus, and the first was the Candida species. This caused mortality about 47%. There's an estimation of the global burden of candidiasis. Candida was estimated to have the rate of about 5 out of 100,000 population globally. That's caused about 1.2 million population infected by invasive candidiasis, and 350,000 of which were candidemia, and more than 800,000 were invasive candidiasis. And in the intensive care unit, candidemia was thought to have the incidence of about 0.24 to 34 patients per 1,000 ICU admission. That's quite high compared with the pneumocystis and aspergillosis. I'm going to show you a common scenario of a case of invasive candidiasis that I think you in this room, or most of you have more or less experience to deal with this kind of patient. This is a 50-year-old woman diagnosed adenocarcinoma of colon, presented with abdominal pain and weight loss. She received TPN through the PICC line for about 1 month, and eventually underwent exploratory laparotomy with bowel resection. Post-operatively, she had fever, admitted to the ICU. And of course, the patient received empirical antibiotic with meropenem due to fever after operation. The blood culture eventually grew coagulase negative staphylococci and vancomycin were commenced and stop meropenem. However, the blood culture reported later show budding yeast, and identification was Candida parapsilosis. This patient never received antifungal until the blood culture became positive. So this is one of the challenges. When we should start the antifungal agent, we should wait until the blood culture positive, or we should prescribe the antifungal agent before. So invasive candidiasis, the most common scenario like this patient is candidemia. And some of the patients may have the dissemination of the candida to other organs that we call disseminated candidiasis, or deep organ candidiasis, including intra-abdominal candidiasis that Dr. Chen just have given a lecture just now, or endovascular candidiasis. The pathogenesis of candidiasis is caused by the source of the candida from the GI tract, or the intravascular source, the central line that the candida can form the biofilm in the central venous catheter. So the Candida colonization could leak into the peritoneum following the operation that cause intra-abdominal candidiasis, or can spread into the bloodstream. The Candida that colonized and in the catheter can also spread to the bloodstream and disseminate to other organs as well. So to treat the Candida, not only the antifungal agent that we use, that we need to control the source of here and remove the source of the Candida as well. So this mainly we found in the surgical patient, the neutropenic patient, the source of the Candida mostly from the GI tract. And the ICU patient, most of the Candida source are from the central venous catheter. So this slide shows the invasive candidiasis that can spread to the skin and the eye, and this is an intra-abdominal candidiasis. There's another scenario that we call hepatosplenic candidiasis. This is not very common. We found in the hematological patient who receive chemotherapy, but during the neutrophil recover, the patient may have the enlarged spleen and liver and have fever. And the blood culture at this stage are usually negative. And after following the neutrophil recovery, you may see the patient have the abscess in the liver and the spleen. That's why we call hepatosplenic candidiasis. And this is very difficult to diagnose because we could not get the tissue because the patient have the bleeding tendency, so we cannot get the tissue here. So like this patient, we try to get the culture from the other source, like the skin, and eventually they grew the Candida tropicalis. So the challenges of invasive candidiasis, I think we should focus on how to diagnose, when to start antifungal therapy, and what antifungal agent to be used. So to diagnose invasive candidiasis, we normally based on the risk factors, cultures, and the serology, but all of these three has a limitation, as you all know. In the ICU patient, neutropenia is one of the risk factors, broad-spectrum antibiotic, multifocal Candida colonization, central venous catheter, major abdominal surgery, immunosuppressive agent, and other comorbidity are all the risk factor for invasive candidiasis. But all of these risk factors are not specific. So we can categorize into two groups, healthcare associated, that we might be able to modify or to reduce the risk factor, like reduce the use of broad-spectrum antibiotic, remove the central line, stop using TPN when the patient getting improved, or all of this. But the host factor that's really difficult to modify, like the neutropenia and the Candida colonization. So if the patient have more risk factor, so it's likely that they might have the invasive candidiasis. So we mainly diagnose by looking the risk factor first. But however, the invasive candidiasis or candidemia is a late cause of sepsis. There are no specific signs and symptoms, so it's not possible to differentiate between the Candida sepsis and bacterial sepsis. We are talking about the Candida score, a lot of Candida score, and this is the two examples of the two scores, Leon score and Ostrowski score. You can see that the factor used to calculate the score is not that specific, like surgery, TPN, sepsis. Only this one is multifocal Candida colonization. You have one. If the score more than 3, so the sensitivity is 81 and specificity is 74% for Candidemia. And also this another score. But we try to use the score in our ICU, but we found that almost all of our patients in the ICU have the score more than 3. So that means that everyone will get the antifungal agent if we use this score to trigger the antifungal agent in the ICU. So it's not really useful in our situation, but it's useful to exclude the candidiasis rather than to diagnose. So if the patient doesn't have, if the score is less than 3 or it doesn't meet this criteria, so it's very unlikely for the patient to have the invasive candidiasis. If we cannot use the clinical diagnosis, so what is the lab? The limitation is that culture-based method is another challenging because it's insensitive and time-consuming and unable to detect the invasive candidiasis without candidemia if we use the blood culture. And non-culture method is not widely available. The blood culture, it depends on the technique you use. The volume of the blood culture must be at least 10 milliliter. Otherwise, the sensitivity will be low. So the sensitivity varies from 20 to 71%. And the turnaround time, it could be more than 1 or 2 days. And if you use the other serology, it would be better, like beta-glucan and PCR method, that the turnaround time was shorter. And sensitivity and specificity are higher. However, this is really not widely available, expensive, and needs a lot of advanced technique. In my hospital, we have only the blood culture, but in some of the hospitals in Thailand, Dr. Oriya may have some data about the beta-glucan. So if we use the blood culture for diagnosis of invasive candidiasis, for candidemia, the blood culture will be positive about 75%, and for deep-seated candidiasis, what about 1/3? So we miss about 50% if we use blood culture to diagnose. Now, when to start the antifungal therapy and what antifungal agent to be used? So many studies has shown that if we start the antifungal treatment early, the patient will have a chance to survive better than the one who received late. And also the source control also important. Like for this slide that you show that the patient who received the antifungal agent and source control within 24 hours has a lower mortality than the one who did not receive antifungal within or did not receive the source control or both. This also the same, that showing that early antifungal treatment and source control will give a better survival to the patient. However, how early is early? So like Dr. Low just mentioned just now, the EMPIRICUS study showing that if we empiric all the patients who suspected of invasive fungal infection in ICU acquired sepsis, who had Candida colonization and multiple organ failure, while waiting for the culture result, is it worth to do that? This is the RCT comparing microfunction and the placebo in this patient, and they show that there are no difference in terms of survival at 28 days. So it means that in the patient who are very likely was suspected of candidemia, and we empiric everyone, so it's still no data to support the use of empirical treatment. Even though they try to analyze in the subgroup, they also show no difference. Similarly, intense study also show that in the patient with a localized intra-abdominal infection, this is focused only in the intra-abdominal, only not candidemia, only requiring surgery and ICU stay. If we start the antifungal early, does it help? So this is comparing microfunction and the placebo, and the social are the same. There's no difference in terms of survival. So this study showing that we need the diagnostic test and with high positivity value to deal with the patient who are suspected candidemia. However, if you want to use the empirical treatment, may be considered as in a high-risk patient, but should be re-evaluated after 72 to 96 hours. And then if there no evidence, we should stop the antifungal agent. Now, the last challenge is what antifungal agent to be used. And we have a problem with the increasing rates of non-albicans Candida and Fluconazole resistant and MDR Candida in our region. And the antifungal agents are costly. However, if we don't use that, the patient might have a very high mortality. This slide shows that in the Southeast Asian country, and the non-albicans Candida are more than Candida albicans. So even the Vietnam, C. albicans and C. tropicalis are pretty much about 40% here. In Thailand, C. tropicalis are more than Candida tropicalis, but some countries still has more Candida albicans. And this slide showing you that there are increasing incidence of C. tropicalis resistant to fluconazole. If we can identify C. albicans, so we don't have to worry about the antifungal agent. But C. tropicalis is one of our problems. Like Dr. Chen just showed the data that they are increasing the fluconazole resistance in C. tropicalis. And in some other countries like Thailand or Singapore, we have increasing the incidence of Candida glabrata that resistant to the triazole also. Lately, we are dealing with another MDR pathogen, Candida auris, that you might heard from the news, that this pathogen resistant to almost all of the antifungal available. This study is the same study I just presented just now. The Candida tropicalis. This is the Fluconazole susceptibility of C. tropicalis, and you can see that Vietnam has the lowest Fluconazole susceptible to in among the C. tropicalis isolate, followed by Thailand and Singapore, and 72% susceptible to fluconazole. And but the Korea and Philippines surprisingly is 100% susceptible. This is the Candida auris that has been identified since 2009, but has been spread all over the world lately in the new. And the recent data from the website of the CDC as on the September 30 showing that there are about 38 countries reported to have C. auris. These all the map, the world map. Fortunately, there are no report from Vietnam. I'm not sure you might have it now, but it's in Thailand. This is the green color mean that we have single case, but actually we have the second case last month already. So they might spread somewhere around. So this is the first of our case in 81-year-old woman in the private hospital. Has identified C. auris by multidrug and sequencing. The genotype was South Asian clade, it's clade 1. And this is the susceptibility test. The isolate resistant to amphotericin B, fluconazole, itraconazole, or voriconazole, but fortunately, it's still susceptible to echinocandin. But no, unfortunately, we have no outbreak and no source identified in this patient, and the patient has a successful outcome after microfunctioning treatment for 2 weeks. And the second case, I don't have the data yet, but we just identified this last month. The concern of Candida auris is that this is the multidrug resistant and difficult to identify with standard laboratory method, and could be misidentified to other species like Parapsilosis humoronii or others. And it can cause the outbreak in the healthcare setting in nosocomial infection. It can have the prolonged colonization. This organism can survive on the medical equipment surface more than at least 2 weeks, and can spread from environment to patient and even person to person. So the last part would be the treatment of candidemia. So the strategy to treat is the first, to remove or replace the catheter if the patient have one, and to empirical treatment with antifungal agent based on the epidemiology data. And once you get the culture back, so you should optimize the antifungal treatment using the antifungal susceptibility result. The duration of treatment in candidemia normally 14 days after the blood culture negative. This is the standard for in the guideline. And the guideline, prefer to use the echinocandin as a first-line treatment, both in the United States guideline or the European guideline. And you can see here the echinocandin has a strong recommendation with moderate evidence, followed by liposomal amphotericin B. Fluconazole must be really careful in our region because we have more resistant isolate with Candida tropicalis to fluconazole. As an empirical treatment, it's probably not a good choice, in my opinion. In neutropenic patients are pretty much the same as the neutropenic patient, but we not prefer to use fluconazole because the neutropenic patient may have a mold infection. So we prefer to have some mold activity in the antifungal agent. After we receive the result back, so the de-escalation should be performed in if the isolate identified as albicans, parapsilosis, or Fluconazole susceptible tropicalis. So if the patient getting better, so we should de-escalate to use the fluconazole. All the patients should receive the eye examination to rule out the chorioretinitis or endophthalmitis, and remove the central eye and this relation. So by summary, candidemia is increasing in the ICU setting with a non-specific signs and symptoms. So accurate and rapid diagnostic tests for fungal sepsis are not widely available, and we really need one. And changing of the Candida species distribution with increased multidrug resistance is a concern nowadays. And novel antifungal agents are needed. So I would like to give some take-home message in my last slide. So for the blood volume, so we really need a very high volume, about 10 ml per bottle, and repeat every 1 to 3 days, ideally once a day, but I think every 1 to 2 days is okay to make sure the blood culture negative so we know the duration when to stop the antifungal agent. Start with echinocandin if possible, otherwise amphotericin B, preferably liposomal amphotericin B is the alternative. And the escalation to fluconazole if possible, eye examination when the patient is stable, or in the neutropenic patient, we perform the eye examination when the neutrophil recover. Remove central eye. Echocardiography has been recommended in the European guideline, but we are not doing in everyone, but we will perform in the one who had persistent candidemia, failure treatment, or relapse. And the duration is 14 days after blood culture negative. Okay, thank you very much. This is all my talk.